So just do about 10 seconds, John, you'll start the
Good afternoon. It's approaching 2 o'clock and we're shortly to go live. Will we get told when we're live?
The thumbs up in the
yes.
Chair, so
yes. I'll take that as the fact that we're live. Good afternoon and welcome to the Health and Wellbeing Board. This is probably the first in-person get-together since probably March 2020. And doesn't it feel good? Yeah, it feels really, really nice. We might be a little bit further apart, but at least we're together. I'm not expecting Abby 4.5 hours this afternoon. I'm hoping that we'll move through things with a degree of pace. And I'm going to start off with agenda item number 1. The appointment by full council on the 27th of May 2021 of no less an individual than Councillor Dr. John Doddy as the chairman for the year 21 to 22. And I think it's a great honour and a privilege to be back here again. Some of you may remember I was here in 2017 to 2019, so it's not an unfamiliar role for me. And I'm just picking up the reins again. So I'm delighted to be here. Do I have to do anything further with that, Matt?
That's the point by Council Chair.
Excellent. Now, the agenda item number 2 is the election of a vice chair. Many vice chairs in the county council exist from within ourselves, and we have a chair and a vice chair, which are county councillors. The Health and Wellbeing Board has always been different, not uniform throughout the country, with different people taking different approaches to who ought to be the vice chair. But in Nottinghamshire, for as long as I can remember, we've always had a representative from the CCGs, which used to be 7 CCGs and then merged into one for the South. And that's always been Dr. Jeremy Griffiths from when I've known, but he can go back further than me, can't you, Jeffrey? Jeremy.
That could be a name.
Jeremy. Where's my prompter? I need a prompter. So what I'm going to do is, under election of vice chairman, I'm going to nominate Dr. Jeremy Griffiths from Rushcliffe CCG as the vice chair for the coming year. Do I have a seconder?
Second nomination. Thank you, Chair.
Thank you to Councillor Wheeler. Are there any other nominations? It's looking good, Jeremy. Yeah. No further nominations. So can we have a show of hands, please? All those in favour? Excellent. I think that's unanimous, Jeremy. That's a good start.
Okay. Well, I'd just like to say thank you. Just to say thank you very much for your support. One of the statutory duties of the Health and Wellbeing Board is promotion of integration between healthcare and the local authorities, and one of the things I will be doing will be trying to, as we move towards the integrated care system, which will be replacing Nottingham and Nottinghamshire Health and Wellbeing CCG, promotion of integration is one of the key priorities, and avoidance of running parallel systems between local authority and healthcare, where integration produces greater value for the taxpayer and for the patient.
Thank you, Dr. Griffiths. Agenda item number 3 is to note the membership of the Health and Wellbeing Board. The Health and Wellbeing Board is quite a big board, but it's also remarkably representative of the people of Nottinghamshire, represented by all the districts, represented by the CCGs, represented by the County Council, represented by the officers. Health Watch. Is Health Watch here today? Have we got Health Watch?
Chair, Health Worker sent apologies today.
Apologies. Okay, we'll get on to that in a minute. The various offices, including Kevin Dennis, who normally represents the Police and Crime Office. So it's a very wide and varied membership. Martin, any reason to read out the particular names of all the members, just to acknowledge them? Just instruct everybody to note the membership. That's item number 3. I'm going to move on then to item number 4, which is the terms of reference of the Health and Wellbeing Board. The Health and Wellbeing Board terms of references haven't really changed since their inception in 2013, having originally been set up by the Health and Social Care Act 2012, and they've remained pretty consistent since then. The first thing is to prepare and publish and maintain a joint strategic needs assessment with regards to the health of the population of Nottinghamshire. The second, and we'll see further on in this afternoon, the importance of a pharmaceutical needs assessment, and we'll come to understand what that means in terms of the provision of pharmaceutical services for Nottinghamshire. We also have to get together and produce something called a strategy for the next 4 years. In other words, to outline what it is that we would like to see achieved for the population of Nottinghamshire over the next 4 years, and that'll be the Health and Wellbeing Strategy. It's one of those things that takes quite a bit of time to develop. In 2017, I travelled to all 7 districts, up to Retford and to Beeston and Ashfield, etc. And we met with the populations there and asked them for their opinions on what they felt should be included and gave them some outlines on what we were thinking. And then we brought that social contact back and used it to influence where we wanted to be. And it's something that I'm hoping to do again. So anybody representing any of the districts, I'm hoping to travel out to all of them again in order to inform us of what people in their areas feel is important to them, as opposed to just what seems important to us. So we'll be getting on with that in the next number of months to have it organised for, I think, Jonathan, 2022 we wanted. Yeah. Excellent. So when we do joint strategic needs assessment, the terms of reference suggest that there are directions in which we want the county council to be aware of the needs of the population, and therefore we can present those needs to the county council and say, this is what we feel needs to be addressed in order to improve the health and wellbeing of the people of Nottinghamshire. Now, that's going to change slightly in terms of what Dr. Griffiths mentioned earlier on, which is the integrated care service. And the integrated care service and its relationship with the Health and Wellbeing Board will be a developing relationship over the next number of months until we agree on where both of those sit as to how the Health and Wellbeing Board influences the integrated care system to then influence what's delivered across Nottinghamshire. And it's very much one of these watch this space type thing, because it's not written in stone, it's not got anything in a textbook that you can read, and most of the councils around the country will be doing their own interpretation of what that means, and we'll certainly be doing that over the next number of weeks and months. We can be asked to do specific things by the Department of Health, and we were asked to do a lot of them over COVID. And the board is also responsible for setting up its own projects and its own steering groups, many of which we've done over the last number of years. So the terms of references are those, and the recommendation really is just for the Health and Wellbeing Board to note the terms of reference, and I hereby recommend that. Do we need a vote on that, Martin?
You can just move and second.
I'll move that. Have we got a seconder? Seconder. All those in favour? Okay. So that is item number 4. Item number 5 is the minutes of the last meeting. I'm going to go through the minutes of the last meeting in the pages. I'm going to start at page 1, moving to page 2, 3, 4, 5, and 6. There's 2 lots of page numbers, but 1 lot for the minutes. So I'm just going to note, Councillor.
I cannot hear a word that's being spoken. Sorry, I'm struggling to hear.
Try and move your microphone a bit nearer to you when you speak.
Okay. Okay. Colin, is that any better? Okay. Actually sounds better. Yeah, thank you very much. Hurry. Give us a later, David, later. Okay, so the minutes of the meeting, I'm just going to recommend that they are approved. I move that. Do I have a seconder? Tell me. All those in favour? Excellent. Now, Martin, apologies for absence.
Thank you, Chair. So I've got several apologies for absence. So Councillor Susan Shaw from Bassetlaw District Council has provided apologies, and Councillor Schuler is deputising on her behalf. Idris Griffiths from Bassetlaw CCG, Fiona Callaghan from Nottingham and Nottinghamshire CCG, with Hazel Wigington deputising for her, Councillor Misen from Newark and Sherwood, Councillor Bradshaw from Mansfield, Melanie Brooks from the County Council, and Sarah Collis from Health Watch.
Thank you, Martin. Item 7, declarations. If anybody has got any pecuniary interests, disclosable or private interests, pecuniary or non-pecuniary, now is the time to declare. Okay, noted as none declared. Agenda item number 8, called the Chair's Report. It's quite a significant report, and because it's the first meeting, I've decided I'm going to go through all 80 items one at a time. It may take some time. In terms of the report, there's a couple of things that jump out, and the first is the Domestic Abuse Act in items 4 and down into 5 and 6, etc., and talking about domestic abuse. It's been rather an unusual year in that the number of reported incidences of domestic abuse in the first lockdown rose significantly through all the agencies which were dealing with domestic abuse. And in particular, coronavirus seemed to create the perfect environment for those who seek to use restrictions to manipulate within partnerships the inability of people to escape trapped environments during lockdowns and the rigorous enforcements of social isolation, etc., which allowed controlling partners to exert an enormous amount of influence over their domestic partners. So it's never been a more timely time that we have a budget for delivery of the Domestic Abuse Act of something like 1.5 million for Nottinghamshire County Council. Jonathan, did you want to say anything specifically on the domestic abuse, or is there anybody who wants to say something specifically on it?
I'll just add that it's a really good example for members of the board who are new of an agenda where it absolutely relies on the contribution of different partner agencies. So this is something where across the local system, certainly the local NHS, but in particular districts and borough councils are very involved. And of course, it's also a real priority and area of focus for the Office of the Police Crime Commissioner. So it's something that that is going to receive a lot more prominence in the coming months with this. Looking back a year or so, some of you will also recall that it was something that we gave a lot of focus to, again, across the local system a year ago, and working again with colleagues in districts and boroughs in particular, we were pleased within the County Council to be able to put in place some emergency accommodation for a temporary period to meet some of those additional needs that Councillor Doddy has referred to. Happily, that accommodation we were able to stand down, but I should alert the board that our local domestic abuse helpline has seen an increase in calls over the last several weeks, couple of months. So absolutely remains a key concern to us, and I think we've yet to see all of the impacts of the latest lockdown playing out in our communities, sadly. Thank you. Back to you, Chair.
Thank you, Jonathan. The doubt is the funding for substance misuse. There's no question again that the amount of drug and alcohol use in lockdown rose pretty significantly, and item 12 talks about 810,000 over a 12-month period to look at substance misuse interventions. In terms of alcohol alone, it's thought that there's something like 80 alcohol deaths per day, and statistics would suggest that we've never had more people dying from alcohol-related liver disease than in the history of record keeping, and that is an area that we find ourselves in. We have, if I remember correctly, Dr. Griffiths had the liver specialists from the Queen's Medical Centre here in the past when we looked at the services that were available in Nottinghamshire when they were introducing new forms of scans and tests. It may well be that it may come that we'll be looking at bigger. Sorry, can you still hear me, Colin?
I could hear Mr. Griffiths absolutely clearly, but I'm still struggling to hear.
Okay, right, Jeremy, we'll have to swap places. So one of the things that interests me is the work that's been done in Scotland and Wales around the introduction of the minimum unit price for alcohol, which was put at something like 50 pence in Scotland and Wales, and saw a reduction of between 7.8 and 8.5% in the overall consumption of alcohol in those populations, which are not insignificant, and therefore going forward, as well as putting money into substance abuse, trying to reduce drug and alcohol use, it may well be it'll be something we'll need to look at whether or not we think that is directions in which we want to go, a bit like sugar taxation, etc., on a more national level. There are 80 odd articles within this, and I'm more than happy for anybody who's got a personal interest or noted any of them to talk about it, ask us questions about it, or bring it forward, as we will be in all meetings to come. There's something in there for everybody, and if anybody has anything that they wish to bring up, I'm more than happy for them to do that now. Colin, can you still hear me? Yes, Sheila.
Can I just ask, we've got a real problem in one of my villages.
Yes.
And it's a place for people to recover, but they're still getting hold of drugs and alcohol. Do you get any chance to look in at that sort of work? Because they're out on the streets, they're frightening children to death who are going to school or coming home from school. You know, it's not nice to see somebody on the floor and weed themselves and everything, you know.
Yes, I seem to remember last time there was a motion came before council on the use of what they call psychoactive substances, creates a lot of the bizarre behaviour of people standing naked and defecating in public places and being totally oblivious to their activities, the monkey dusts and the angel dusts and all that sort of thing. And it is a very small percentage, but they're an exceptionally visible group, and therefore they give the perception of perhaps being much bigger, whereas alcohol remains the bigger problem. Jonathan, did you want to say anything on that?
Thank you for the question, Councillor. And and Chair, you're quite right. It's something that's received some focus over the last couple of years or so. So outside of the meeting, I'd be very happy to follow up with you on that. The work within, Bassett Law is very much led and championed by Bassett Law District Council, but working very closely with our own substance misuse services, which are commissioned by the County Council, and with the local NHS, including colleagues from the Healthcare Trust. So well placed to link people in with mental health care services. So outside of the meeting, I'll be happy to follow up, just understand what the specific issue might be at the moment, and then see if we can address that specifically. Thank you.
Thank you, Jonathan. Thank you, Councillor Place. Could I ask Councillor Wheeler for his question?
Thank you, Chair. Is there any way that we could look at the issue of county lines and the impact that's had on young people during the coronavirus pandemic? Because in terms of children's, young people and emotional mental health, I know from my own personal work experience that a lot of young people have been impacted by those issues around mental health, but also they've been subject to, I think, a lot of young people. There's danger that quite a few young people have slipped through the net as a result of not having the services that they would have had in place normally. So can we have something in there, not just about the mental health impacts, but around the impacts of mental health sort of related with the impacts of county lines and safeguarding more generally speaking, please? Thank you.
Yes, of course, Councillor Wheeler, and it is always the more vulnerable individuals who fall prey to being abused and intimidated into the movement of drugs. We have had a number of presentations while I've been here with regards to county lines and things like modern day slavery, etc. Jonathan, did you want to contribute?
Just to add, it's also something that is very much the focus of the Safer Knots board, and is something which gets picked up there as well. So in terms of following up on that specific matter, it might be something which in this instance is better addressed through the Safer Knots board rather than the Health and Wellbeing board, but recognising that these are kind of our overlapping agendas, aren't they? So that's not a butt pass, but perhaps I could follow up with you after and we'll just make sure that identifying the specific issue, and then we can figure out where best to pick that one up. Thank you.
Thank you. Dr. Griffiths.
Thank you, Chair. It's just really in relation to the Chair's report, items 57 and 58, with reference to government's loneliness strategy. I think one thing that the COVID pandemic has done has thrown a light on individuals who don't have significant support networks and who've found the challenges of the closing down of society a significant challenge. And I just wonder whether there's a possibility at some point whether we could review loneliness as a subject matter for maybe a paper or a discussion around the actual prevalence of loneliness in Nottinghamshire. And the impact on things like health inequalities, poor outcomes for individuals, and the potential options that we have in terms of some of the innovative strategies around, for instance, social prescribing, services within our communities. So I just wondered, I think it is worthy of attention.
And there is no doubt that we're engineering little by little a socially isolated generation and a socially isolated society as we move towards more people working from home, etc. And that was one of the big challenges of people working from home, was that lack of contact with colleagues in order to just have that cup of coffee at the coffee station, etc. I remember in particular a study done on people who lived at home with pain. And it looked at a group of people who had pain from arthritis and who were living alone. And it looked at a group of people who were living with people. And it found that on average, the people living alone were on at least one more pain relieving medication than the people who lived in company. And it sort of gives you the whole understanding of that benefit of social interaction. It's a medication. There's no question about it, and its absence is perhaps nothing less than a disease, Jonathan. Jeremy. Councillor Martin.
Thank you, Chair. Congratulations on your new post. And you, Jeremy. Yeah, in relation to paragraphs 50, 57 and 58 and 59, really, because 59 is an area close to my heart. You know, suicide prevention. I'd like to know, you know, it sets out commitments designed to prevent suicides. And I think that's a reciprocal thing. And I'm really glad that we've got two doctors as chair and vice chair, because you're on the front line when it comes to people visiting you. And we've had this conversation before, Councillor Doddy, I know, where that 10-minute window is not enough. And I think we could have some kind of traffic light system where we deal with mental health issues, domestic abuse and suicide residents who come in who are presenting with those problems. In answer to the loneliness question, during February in Ashfield District Council, we did wellbeing checks and we rang about 45,000 people up. And that was really phenomenal. And it's just a simple phone call. Hello, how you doing? You know, this, that and other. You've got people supporting you and all that. And it was a very, very simple and direct way to help people combat loneliness, especially septuagenarians and octogenarians, because they had no help, not a cat in hell's chance of getting onto the COVID vaccine programme because they were phoning through. So we were actually booking them in. And it was a really, really rewarding experience and a very, very reciprocated. The people really, really liked it. And I think it was a very good way to combat loneliness, because you're not actually going round to the house, you're ringing them up. And if they don't want to talk to you, they just put the phone down. So that was a very good way of dealing with it. But I'd like to do a bit more work on the suicide prevention pathways that are currently in place and how we could probably make them more robust with some kind of traffic light system. So when somebody comes into the doctors with domestic abuse or mental health issues or threatening to commit suicide, that it's flagged up in other areas almost immediately.
Thank you, Councillor Martin. It could be that you've hit upon, perhaps with conversations with people who live on their own, the most cost-effective public health intervention strategy that exists. It costs very little, and yet what it brings into people's lives is enormously considerable. So I think it definitely, Jonathan, something for the Health and Wellbeing Board to consider.
Yeah, I'd be pleased to give some focus to that. Amongst the full range of public health agendas, we've had during this last year to stand down many of them, but I'm happy to say that things as critical as prevention of suicide are things that we've been careful to keep going. In the last couple, actually it's earlier on this year, several months ago now, we were pleased to secure some additional funding, which we'll be using to strengthen some of these pathways that you were referring to and some of the partnership arrangements around this. So it's something that perhaps at a future board meeting we come back and provide more information on for the board.
Yes, indeed. Councillor Place.
Can I just say that I welcome this funding that's come forward, because I lost a grandson 2.5 years ago, and it's really welcoming. Yeah.
Thank you, Councillor Place. Oh, there we are. Lynn.
I just would like to, looking at the substance misuse, would like to know more about the wider rehab services and regulation of providers, and that's building on Councillor Place's suggestions earlier and discussions about a particular incident. The other thing is, out of Councillor Martin's, what Councillor Martin was saying about the phone calls, I wonder if we can, building on COVID-19 and not losing the learning that we had, start to provide a best practice log that each individual council actually has found that initiatives that have worked, and especially the small changes that have made the biggest impact. And finally, on the loneliness and isolation, I would dearly like to see a piece of work about our 0 to 3 year old cohort, because they are a cohort that have actually been born during or soon, quite soon before COVID impacted, and they are potentially not learning how to socialise as readily. And is there something that we need to put in place that makes sure that we are enabling those children that were born in lockdown and just outside of lockdown to actually socialise more readily?
Yeah, and not only that, but the mothers who gave birth during COVID, often in isolation without partners present and without that support to help them through the early breastfeeding and early months of a newborn baby. A colossal area, no question about that.
To come back on that, it's the isolation that the mothers have had afterwards, notwithstanding the actual birthing process, but actually in their formative years, in their child's formative years, and the potential lack of support around young mums.
Yes. Nigel.
I did switch it on. That's better. Yeah. So yeah, is it something that there must be, there should be more work on it, perhaps more measurement of what, and connections within the local community, because I think the connections within the local community are key. And just on loneliness, I suspect that issue is more of an issue during the winter months. When we have days like this, it's not so much perhaps of an issue, so probably more of an issue during the winter months.
Yes. Yes, because you've got your seasonal depressions and mood changes on top of all that, and the shorter days. There is no doubt that COVID has thrown up a colossal series of challenges in addition to what's always existed. So not only have we had the challenge to deliver public health, etc., we now have the added uniqueness that's been brought about by a year of loneliness, of isolation, and of unique challenges to a generation, be they newborn children, be they mothers, be they school-going kids who've lost that first year of life, be they older kids who haven't been able to do their exams and GCSEs, people going to university, people who've been furloughed, people who've been made redundant. You could do all ages and it would be equally startling, the effect that it had on them. Councillor Smith.
Thank you, Chairman. Yeah, just to very briefly kind of say, I'm very pleased that the aspect of newborn children and the kind of plight of mothers during COVID has been raised, because as somebody who had a baby a couple of months back, me and my wife, it's a very unique, very specific situation with a whole host of, I mean, it's stressful anyway, but then suddenly you're kind of completely, pretty much on your Todd. So I'm very, very pleased that that's been raised right off the bat in this meeting.
Yes, and the challenge of getting the support through health visiting, etc., just getting your baby weighed, just getting advice on feeding issues, just getting advice on the normality versus the abnormality has been, relatively absent. But I'm pleased to report that it's pretty well back to normal now in the communities anyway. Jeremy, anything to?
No, I guess I'm just very keen that the Health and Wellbeing Board isn't a talking shop, and that actually, if there are key items like this, that we think that there's some mechanism whereby we can actually use concerns to incorporate into our future strategy going forward.
Like the work programme, Jeremy. Thank you. Well, we nearly got through all 89 there. I think we've done mighty well. This Chair's report is to consider whether there are any actions required by the Health and Wellbeing Board in relation to the issues raised. And we've had a considerable contribution over that, particularly around loneliness, etc. I move the report. Can you second it, Jeremy? All those in favour? Thank you. So we're going to move on now to something called the local area coordination uptake, which is item 9. And I have Claire Gilbert. So, oh, right. Stand down, Claire. Yeah. I think we're moving on to population health management. Population health management is the new buzzword which we will all become remarkably familiar with as we go through the year, how data-driven our interventions are going to be to the statistics that are available to us. But I'm not going to steal your thunder. Carry on. Yes.
Okay, hi everybody. So I'm Amanda Robinson. I'm the Programme Manager of Population Health Management for the ICS, the Integrated Care System that's previously mentioned. If you just want to move on to the next slide, Brian. Thank you. Sorry. Okay, so the purpose of this presentation, and I will try and keep it very brief. I did come, I think it was last February time, and did a presentation for the board around what population health management was, and I suspect some of you were here then, but I think there's been a change over the last few weeks. So just really to recap on what population health management is for the board, our approach and how PHM supported COVID over the last 16 months and continues to do so. And then the current projects that link quite nicely with everything that's been said here today, and I could have jumped in at numerous occasions with things that we can actually do to help identify some of these people across the patch. Bryony, thank you. Okay, so PHM, it's an approach. It looks beyond health and care. We look at the wider determinants, the factors that impact our local population. So we're looking at finance, we're looking at housing. We use data. Nottingham is really data rich. We're able to understand our population more so than the rest of the country, if I'm being brutally honest. So we've got something that's called GPRCC, GP Repository for Clinical Care. That has feeds from obviously the GP feeds, it has mental health feed, we have social care going in there, and we've also got the acute data going in there. So when we come to look at the population, to stratify that population, we've got everything more or less in-house, and it continues to build. And I think the data team certainly are looking at widening what other data we can add to that part, you know, looking at 111 data. Personally, I'd like to see optometry data in there, dentistry data in there, to get that whole population view rather than just a health view of the population. Bryony. Okay, so the PHM team was a very small team pre-COVID. There was only actually 4 of us in the team. And I think if anybody was around last year, we were telling you around what we were working on. We were working on the diabetes work stream across the patch, understanding what our population looked like for diabetes. But then in early March, the PHM team integrated into a data and information cell team that was the response for COVID. It was the emergency response and formed part of a system-wide COVID response from a data and intelligence perspective. The team have worked 24/7 and the analysts have done an absolute job, more so than anybody else across the country have done. And we've been able to support the system with monitoring the R8 locally, looking at the bed modelling, looking at how the acute beds are being used and how we can keep people out of hospital through COVID. We were monitoring excess deaths, we were looking at PPE. So a whole spectrum of information that we were actually giving out in the beginning on a three-day-a-week basis. This was being thrown out across the system to be used into local decision and planning purposes. It's been reduced to once a week now, but it is still used. And Jonathan, I think you'll agree, you still use that for some of your briefings on a regular basis now. So the PHM team have supported with the data and information analytical team, and this has been at the core to managing COVID for Nottinghamshire. Bryony. As well as doing the high-level briefings across the patch, the team were asked very early into COVID last year to look at a mental wellness rapid review, and that was around the COVID. So it was a very rapid review, and it was around the impact of COVID on people's mental health across the system. It is available on the website, and I have, within the presentation, put our website on there. But it was looking at people, as you said earlier, about the vulnerable, the isolated, families and children. People were being furloughed. We've got bereavements going on. We've got people being made redundant. So actually, the PHM team pulled together this rapid review with impactable interventions for this population, where that population was, because through our data we can identify where these people are. Come sort of August, September, we were aware that flu is obviously going to cause winter pressures. Through last year we were looking at, we were up to capacity in the hospitals with COVID, so we needed to make sure that a flu programme was rolled out. And again, the data and intelligence led the flu vaccination programme. We could identify the people that needed the flu vaccination, and we could target interventions to get to those people. And then obviously from December, January, we started the COVID vaccination programme, and this has been probably the biggest win across the system. We've managed through our own data, local data intelligence, to identify those that were living alone, those that were housebound, those that were clinically vulnerable, through all the JVCI guidance, through all the age groups, and we are still continuing to do that. So I think it's over the 25s this week, we can still identify this population. And I just wanted to let the board know today that we reached the 1 million mark yesterday. So we're over the 1 million mark for vaccinations for the patch. So just 0.1 to go. So again, all this work comes with impactable interventions, and certainly from the COVID vaccination programme, we've got communities that didn't uptake. We've got interventions. We've actually, within the city, for the Black community, we managed to tailor interventions to actually increase that uptake. For Mansfield and Ashfield, we've got a Gypsy Roma community. We've managed to pinpoint these people, get into their community and actually advocate getting the vaccination. So I think for Nottingham, we've achieved leaps and bounds with the vaccination programme. Bryony. Thank you. So in addition to everything else that's been going on with PHM and the data and information cell, we've still managed to try and maintain our work programme that we originally set out to do. So we've just this week hopefully finalised an ageing well pack, and again this is looking at our over 65 and over population. We can identify where these people are, we look at the demographics, we can understand where they're lonely, we can start to target interventions across our system. So that pack is due to be released. I'm just waiting for final approval, hopefully this week, and it will be available on the website. What I would like to say is that I'd like to do an exec summary and come back to the board with that, because I think some of the things that's been mentioned today actually will be useful for some of the people around the table. So I'm happy to come back and do that. We're doing a mental wellness review, a full mental wellness review. So again, picking up some of the points that were mentioned earlier. Mental wellness, as everybody will be aware, is huge, and it's where do you start with mental wellness? So what we've decided to do is cut it into parts. Not saying that they're all singular, they cross-cut each other, but because of looking for the data and how we go around our PHM approach, we needed to take it into sections. So the analysts are currently working on serious mental illness, with hopefully common mental illness will form part of part 2. I've put the parts in there. We're looking at children, young people, suicide, personality disorder, learning disabilities. They won't necessarily appear in that order. That is just me putting it onto a presentation. That's not been agreed. But what has been agreed is serious mental illness is being looked at now and is currently underway. All the PHM programmes of work can be found on the following website. We have got the diabetes work on there, we've got the flu vaccine work on there, we've got the mental wellness rapid review on there. So if you just want to have a look and a taster of this sort of data and information that we can actually drill down to, not just at a system level, but we can take it right down to PCN levels, right down to the primary care level, to actually pinpoint and target some of your populations. So I think that's me in a nutshell, Bryony. And I'm quite happy to take any questions. I've just stunned everybody into
Thanks
silence.
very much indeed. 1 million vaccines, that includes first and second vaccines? Or are you saying that there's been 1 million first vaccines of the 1.1 million people in the entirety of Nottinghamshire County Council? There's only 0.1 who haven't been vaccinated.
Yes.
That
For a first and a second, yes. So we've done all the first 1 million.
It seems quite an extraordinary achievement.
And that was yesterday. Yeah. That was achieved.
Councillor Walters.
Yeah, hello there. I like the presentation. Just a quick question. Did you also capture domestic abuse data on that? Can we also get that on the website? Or?
So I think what we've got currently is data and information that we actually own, but I think as the system integrates more, as Dr. Jeremy Biff said earlier, I think we've got more opportunity to look at local authority-led data. It has been integrated somewhat over COVID, and some of the traditional boundaries that we've had around data sharing agreements have been broken down. So I think that will continue. And I think, Jonathan, you'll probably agree with me that, you know, we are in a position to start, hopefully once we're an ICS and we're integrated a little bit more of that data will flow more freely. So we will be able to identify that population and overlay the interventions. But certainly for the alcohol abuse, we know where people, where the alcohol use is, we can pinpoint this population. So yeah, smokers, obesity, we have all that information, and I think domestic abuse is just another one that needs overlaying.
Thanks. Data driven, and the biggest returns come from intervening in the places with the biggest problems. But if you don't know where those biggest problems are, you can't intervene, which is part of the idea of population health management. Jonathan.
Thank you. Yeah, it was just a note of caution around the sharing of data for some of these cohorts. Amanda's absolutely right, and I think you're spotting the potential in population health management for us to be able to get sufficient information together to then check that we are systematically applying all of the right interventions across the right groups in the population. The but in there is that for a cohort of people who are survivors of domestic violence, there are particular sensitivities around sharing the information in any way that is not very carefully pseudonymised. So, and indeed, there are one or two other services that we commission where we just have to think quite carefully about that. Indeed, the GPs themselves are properly very careful about what data is shared and how that is done, and the governance put around this, so that we don't end up in a situation where inadvertently information that is personally identifiable gets out there. And you'll appreciate that's particularly important for something like domestic violence.
Thank you. Dr. Griffiths.
Thanks, Jonathan. If I just pick up on that, I think there's obviously there's huge amount of potential, isn't there, as we are able to investigate systems, public data, private data. I guess what I'm interested in is there's a huge amount of data that underpins the JSNA. And I guess what I'm keen to understand as we move towards this integrated system, whether there's some underlying overall strategy for Nottinghamshire about how data potentially is going to be integrated, how we deal with the governance, how do we ensure that actually that we're not developing pieces of work and running in parallel with each other. So I'd like to understand a little bit more about that, and I wonder whether you've got any information there or whether this is work in progress.
I think that was directed to you, Jonathan.
So, Jeremy, in honesty, I can provide you a bit of an answer. You're right, again, just to emphasise the potential that there is in the kind of individual level information which we're able to capture as part of the population health management approach that Amanda's set out. But much of that information is right down at the level of individual. You mentioned joint strategic needs assessment, which, if you like, sits alongside a population health management approach. That is much more about identifying groups rather than individuals, and as you're aware, and then identifying what evidence we have about what works for a group of people with that kind of condition or health need. The work that's just starting to kick off within the integrated care systems at the moment is about how they make best use of the joint strategic needs assessment in the commissioning priorities that they set within the ICS. And there's a bit of a reciprocal relationship here between the integrated care system and the Health and Wellbeing Board. So one of the things which we'll need to make sure that we get here is a really good, strong, coherent steer from local NHS colleagues about some of the themes and topics which they wish to be addressed within the JSNA. Once that's done and a set of recommendations have been produced in the JSNA, there's a bit of kind of holding to account then, because actually the local NHS, as some of us were discussing earlier on, have a statutory duty to give regard to the joint strategic needs assessment when they're actually putting commissioning arrangements in place. So there's a kind of a bit of reciprocity there in the relationship. Now, you were putting your finger more specifically, Jeremy, on the strategy around some of the governance for handling this. That bit of it I can't answer in detail right now, other than to say that I know that the ICS did appoint, can't remember the job title they gave him, but they appointed someone to look at the data analytics and IT information technology side of things right across the local system.
Thank you. So yes, data to improve the quality of care and to shape the outcomes of the population, but would also regard for the cost of those interventions. Amanda, did you have anything further to say before I move to recommendations?
No, not unless anything. Any more questions? Oh, sorry.
How are you addressing what data actually gets recorded? So it's a little bit of a rubbish in, rubbish out. And therefore, how do you talk to professionals, etc., as what you want out of that system? And I think, generally, you might want to know certain things about a given population. But do the actual health practitioners in that area ask the right questions? So, for instance, if health visitors are going into homes and not directly asking if domestic abuse is happening in that home, then that's a hidden agenda, a whole hidden agenda. So how do we address the fact that we need to be able to pull the data out of the information recorded?
So I suppose in response to that, we only get data that we know about. Yes. So again, with the vaccine rollout, we can only roll out to the people that are actually registered with the GPs that we know about. So it's very difficult to, you haven't got data on the unknown.
Exactly, yeah.
So, but that said, you would hope that you have got a majority. I know there's still inequity with a minority, but as a first cut, we need to go with the majority.
So in that term then, how are we talking to our health and social care, etc., providers in explaining to them what data we need to be able to draw out of the data warehouses and looking at what we need to know about our population to actually build a really specific and well underpinned JSNA?
Can't talk about the JSNA.
Yeah, I think that's
but what I can say is, from a population health management point of view, each work stream that we've worked on, whether it be the diabetes, whether it's the ageing well that we've just completed, we have a task and finish group, and that is with health, social care, voluntary sector. We have senior clinicians, we've got consultant clinicians. So when we start to, one of the second steps that we do is to look at what is the outcome for that population. What outcomes do we want to achieve for that ageing well population? And it is the wider task and finish group that decides the outcomes we want to achieve. Once we've got the outcomes, then we start to look at what are the characteristics of that population, what do they look like, and then we start to do the data search. So it's the questions that drive the data search to then achieve the outcomes.
Right, so I think my question is, what actually drives the data going into the front end of the machine?
Jonathan.
Yes, go ahead, Jonathan.
So there's a couple of thoughts that occur to me. I'm going to have a shot at answering your question, but I wonder whether it might be worth us putting together maybe a session, maybe even tacked on to a board session around population health management, because I think there are some important kind of underlying principles and methods that we've had to sort of skate over today. But to see if I can answer your question, Lynn. So I commissioned some services within public health. So, for example, some stop smoking services. Now, Jeremy has been on to me for several years now because he's interested as a GP in getting hold of better quality information about which of his patients are taking up the offer of a stop smoking service, first of all, And secondly, he's quite interested really to know, and what was the outcome of that intervention? So although it's taken, frankly, an age and longer than I would like to be honest about to put in place, we're working with the chap who heads up this, all of this GP data and that feeds into the population health management system to provide data from my stop smoking provider into that system so that in due course we have better information available for decision makers about what interventions are people getting. So out of all the smokers in my practice, how many people have actually been offered a stop smoking intervention? And of those who took it up, what was the outcome from that? So that's just one example. So each of us as commissioners needs to be working with our provider organisations to make sure that they are providing that information into the population health management system. Now, I just need to check whether I'm completely wide of your question or whether that is somewhere near the mark.
I think basically what you're saying is the KPIs are driving the data into the machine. Therefore, in actual fact, the information that you want to see and the KPIs will drive the data in, and so the providers will disseminate down to their practitioners what needs to be recorded.
So in this instance, we know what an enormously negative contribution smoking makes to the health of the population and the extent to which that erodes healthy life years. So it's one of the things that we commission. There are people like GPs who really want to know what's going on down at a local level with their patients and how effective is it. So that's why I'm asking for that information from my providers to be fed into the system. It'll be useful to people like Jeremy and his colleagues.
Thank you. Councillor Martin.
Yeah, that's one of my things, Jonathan, actually. When the Suicide Prevention Service comes to health scrutiny that the county pays for, they always come with the statistics of how many people have committed suicide. They never actually come back with the statistics of the people that they saved or stopped from committing suicide and how they did it. So that's another thing, because we've got this flat line figure and it's remained the same since 2004. It's about 14% every year and no impact on it whatsoever. So we're paying all this money out for this service every year and yet we're making no detrimental impact on it. We leave it to the doctors, they go into the doctors, they're there for 10 minutes and then they're off again and it's a cycle.
So if I have a shot at addressing that, first of all, let me say, but behind the numbers that I might bandy around, I'm aware that there are individuals, and that's a terrible loss. But in terms of evaluating the effectiveness of interventions which are about preventing things, there's something that it's really difficult to count the things which didn't happen, the things that you avoided. Around suicide prevention, notwithstanding the terrible loss that we do see in Nottinghamshire, in fact, compared with a number of other areas, if you will allow me to talk of it in terms of performance, we actually perform pretty well. That's not to say we shouldn't be doing more, and that's why I'm pleased to be able to report that we've secured some additional funding that we'll be able to apply to strengthen some of the partnership working and some of the pathways, and I'll be pleased to bring back a report to board in due course. But what we will set out for you is that actually holding it at a flat line when some other areas are going up is not a massive success, but actually, relatively speaking, it's good. What I can't count for you are the individuals whose suicide was averted, because actually that's in the nature of prevention. It's very difficult to count the things which didn't happen.
Thank you. Jeremy.
Thank you, Councillor Shule. I think your point is really important. I absolutely accept that we can only analyse the data and make inferences about about the conclusions from it based on the quality of what goes in. And I think that's something that is that sort of Kaizen type approach, which is about continuous improvement all the time. I think one of the challenges we find from a general practice perspective is that a lot of the long-term conditions, chronic diseases, if I can call them those, are better coded within systems. So, for instance, if somebody has diabetes, high blood pressure, heart disease, the codes that are applied within systems are much better input. And probably the reason for that is the majority of that work is done by the nursing teams, who are more used to working with computer templates. General practitioners tend to be more of the filterers, so they'll deal with several conditions maybe at once. And as a general rule, they're probably more likely to use free text as opposed to actual coding. Okay, so one of the big challenges is about how you improve the coding that's done by the general practice population. And I would like to think that as we move forward with the integrated care system, that we may well be able to look at, for instance, preferred codes that could be used that may well input on our JSNA. So if we could issue a series of preferred codes for scenarios that impact on work that the local authority commission, then I think we're going to make progress. And I think that's something that we potentially can do in future. But it is going to be very much about, with time, things will move forwards. We have a series of general practitioners maybe who don't type as quickly as the new cohort. That's just the reality of the system. But I don't think there would be significant opposition to doing that sort of thing, as long as people could see what the end result was that they were trying to achieve. If clinicians within the NHS knew that by virtue of them entering data into the system, that would enable local authority colleagues, including public health, to design better services, then I think there's a win for all.
Thank you. Councillor Wheeler.
Thank you, Chair. Can I just ask, do you get data from schools to determine how services are delivered? You don't? Okay, because the reason I'm asking that is because obviously with schools, there was a mental health crisis before COVID, and schools were referring through to CAMHS. There was a promise of the mental health work in schools, but we've not seen it yet. And or some schools might have it, but others haven't. And there's also the emotional literacy side of stuff. But there's also been a huge increase in safeguarding referrals through to the safeguarding leads within local schools, primary and secondary. So it'd be interesting to see how you could gain data from schools to ascertain how you might be able to deliver services moving forward. Thank you.
So I suspect if children are in schools, they'll be registered with a local GP, so we would potentially have that data at GP level. Safeguarding, we wouldn't get that data currently.
The reason I'm asking is because in terms of the work around mental health, we've seen an increase in mental health cases within schools, but we've not seen any service delivery to match to sort of alleviate some of those issues. That's why I'm interested in the data that's being presented, possibly by GPs, possibly by social care, possibly by other providers. Thank you.
Thanks. Councillor Smith.
Thank you, Chairman. If I could just loop back, did you say it was we've now hit 1 million vaccination doses? If I, Chairman, could just kind of just re-emphasise that is exceptional. That really is exceptional. And I'm going to be slightly cheeky and say, as a 28-year-old, I'm probably in the minority of people in this room who haven't yet had a dose of the vaccine. but we're only here because of such a fantastic vaccination rollout. And I think, you know, especially in this meeting, any opportunity to kind of praise the vaccination rollout, I think we should take it, considering a vaccine didn't exist, you know, relatively a couple of months ago. So any opportunity, Chairman, to praise the vaccine. I'm
informed by Councillor or Dr. Griffiths that over 25s are now eligible for the vaccine. So if you disappear early,
booked in, Chairman.
If you're booked in, yes. Excellent. So I think that's one of those things going forward, population health management. We're going to hear a lot about it in the future. I think that there's a certain merit in Jonathan Gribben's suggestion that we may tag on a little bit of an information session with regards to it on one of the meetings going forward. Could even be worthwhile inviting some of the people who are the orchestrators of it, such as Mike O'Neill, who did the health scope based in Stapleford with regards to how they evolved these systems and where all the information comes from, which I think will be enormously enlightening. And I can see that the future health and wellbeing strategy will be largely influenced by population health management. I'm going to move to the recommendations that we received a presentation on the population health management approach and the progress to date, which is fantastic. Thanks very much. And to consider whether there are any further actions identified that can be used to improve health and wellbeing. And I think we've spoken about quite a number of those. Thank you very much, Amanda. So we're going to move backwards now to agenda item number 9 and call upon the presentation for local area coordination and Claire Gilbert. Thank you, Claire.
Put on the microphone. Hi. Yes, I wanted to come today to kind of really preempt a further session that is going to be taking place next month, which will go into a lot more detail about local area coordination and hit some of the markers that have already really been talked about today. So local area coordination is an approach that's been followed in many areas for many years and is overseen sort of by an umbrella organisation called Community Catalysts. And local area coordination is very much steeped in working in a very, very community-based way around prevention. So if you could move on, Brian. So this works alongside a lot of other sort of initiatives that we know about, sort of link workers, community prescribers, etc. But it's an all-age support model. So it's trying to work with whole families. It's very much based in very, very locally within communities. And really, it's trying to support people to support themselves by linking them up, by helping them to look at within themselves, within their families, within their communities, to resolve the issues and stresses that they've got, but also where those things are missing, to kind of put those things in place within their community. It's been a very powerful tool, sort of in the places where it exists, and it's very much an approach that we want to explore within. It's come from ASH, but as I say, it is all age to support and underpin our prevention strategy. And what we're seeing this is a first step that we want to take of a much longer journey in terms of embracing this approach and seeing how we can use it with all our sort of health, social care, community, district partners to take this forward. So it's very much, you know, it will pick up on some of those issues that have been talked about, such as loneliness. It will probably pick up on the issues that we've talked about, such as, you know, potentially such as domestic abuse. It will have the approach is very much look at people about where they are and what they need. Our aim is that it will kind of work with those people who haven't yet accessed social care services and who are perhaps on the brink of needing those services. If I can go on to the next slide, please. As I said, this forms part of an ASH prevention strategy that I'm currently leading on for the ASH team, which also links to a corporate prevention strategy and works across adult social care and public health. And we're just beginning to bring in public health partners more into this. We've got lots and lots of things in place within the council around prevention, and obviously our wider colleagues within health have as well. But what we're aware of is we're not very clear about the architecture, about how we bring them together. What's the framework that we set that in? How do we know that we're doing the right things at the right place in the right way? And so part of that journey is to set up these local area coordinators to help us learn from really ground level what the needs are, what's working, and how that will inform and shape our prevention going forward. And so we see all of these different kind of elements that we want to bring together under the ASH prevention strategy. And as part of that, we have formed an ASH prevention board that also will be the same board that will oversee the local area coordination work as well, because we see the two as just being so integrated and aligned in terms of how we do that. So if I can move on, thank you. So we went to the ASH committee back in February to agree the funding for this project, and it is we're trying to avoid the word pilot, because what we want to do is basically it's a seed project to start it, and hopefully that we can gain enthusiasm, support, and it will have to be a kind of whole system support. This isn't an adult social care initiative. It's a much wider initiative across children and adults, health partners, district partners, and so we want to kind of bring people along with us on this journey. But I think in order to do that, we need to have it operating within Nottinghamshire for people to see it, to see what it's doing, to understand it. Community catalysts are helping us along this journey, and we're meeting with them very regularly, and they are helping us develop the approach, and they have lots of peer networks across the country of other services are doing a similar thing. In Derbyshire, it's one of their main models of operating prevention and early intervention. So we've got kind of a bit of a project plan. We're looking at how it might work. One of the key things is the leadership and who needs to sit on that board. So we've got some people that who are already kind of joining us on that board. But one of the things I'm particularly keen on exploring is where we cite the three workers that we've got initially. So although we know we're going to cite one in Bassetlaw, one in Mid Notts, one in the South, they are then going to be in a very within specific communities within those areas. We can't have them working across the whole area. These are people who are going to work in a very community-based way. And so I'm really keen to understand the district council or councillors who say, yes, we want this here, because if I've got your backup and support, then that for me is a really good driver to say, we know that if we put that in that place or in that PCN, and those people are enthusiastic about it happening, that will make it happen. So I want to kind of almost, engineer it about where I see the enthusiasm and desire for it to be there. That's the places we'll explore to put it. So I kind of want to learn from other people about where if you want to grab a slice of the pie, then I'll come and talk to you about it. We'll see if we can make it happen where you are. So that will help then, and then those people will become part of that leadership group that will steer how the project evolves. So that's why it's very much about engaging report. So I kind of want to engage the Health and Wellbeing Board in this journey to kind of say it's really important that we have you signed up to this approach, to understand this approach. And that's why we're going to have a much bigger, so this is a very brief introduction really, this is my taster to say Community Catalysts will come and help us run a workshop in July that will be much more showing you examples of what's happened, what's worked, how they've done it elsewhere, to kind of really model what good can look like in Nottinghamshire, to kind of to get that buy-in, and it may be at that stage that we then kind of go, right, these are the three areas we want to take this forward in. But I've kind of wanted to introduce the kind of this today, and to tie that up with the many initiatives that I know are already happening across health, social care in the districts, and and it will build on some of the things that we've learned from COVID, and I think that will be key as well. So just to take us through to the next one. So we've the post initially will sit in my team, because I think what we want to see is to inform us from a strategic commissioning perspective. I lead up the ASH adult commissioning team, but I think longer term our vision is that it will probably be hosted within the community and voluntary sector. I think that's where it probably best sits, but this is just in terms of it kick-starting. Talked about kind of getting that leadership group, and I think that's really key to that and to that buy-in, and that's what I'm here today. The approach that we're going is, because we've got the maximising independent service within adult social care, who are doing some of that kind of engagement work and enablement work with people who are already known to our services. We want to sit that very much at that people who are not yet known to adult social care is really key for us. Once we've kind of identified the locations that we want to work in, then we want to work with those communities and co-produce it with them as to how it's going to look. And probably each worker will do it a little bit differently. There is, in a way, it's a very, very individualised model that looks about what works best with that community and those people and those individuals. So it isn't a one-size-fits-all model. It's a very individualised model. So that was just to go that, and I won't go into the roadmap is just to say we're kind of where we're on that journey, which is that we've engaged community catalysts. They started with us in May. We've got the first sort of our board meetings in this month. We're working up job descriptions, and then once we've identified localities, then we will begin to do the recruitment. And initially, at the moment, we've got sort of 18 months funding once the posts are in place to test this work. So really, all in terms of what I'm asking for today is just to really to share this with you and to sort of invite you to the session in July. But I'm so happy to take any questions. What I've also shared, which hopefully can be shared with the notes that go out for minutes, is there's a lot more information on there about this approach, and there's also a video, The Story of Differences, a little video clip of somebody who's benefited from the input of community catalysts, and then himself has been a benefit to other people, and it's a really powerful example of somebody who was just, whose needs were looked at from his perspective through his lens, and then enabled him to take himself out of the kind of situation he was in, and enabled him to help others. And I think, and there are many more powerful stories like that, some of which undoubtedly we'll be sharing with you in July.
Thank you very much, Claire. Between talk of taster events and slices of the pie, you certainly made me hungry. It's one of those difficult concepts to put into the jigsaw, and I'm looking forward to the workshop on the 28th of July to get an overview with regards to it. Dr. Griffiths.
Thank you for that. Really interesting. One thing I do away from here is I mentor the social prescribing link workers from across Nottinghamshire. And I know this is your session now is not necessarily about design, but the sorts of things that they have problems with. And I don't know if people are aware, but essentially one of the things that the government have done is try to develop a new range of staff that have come into general practice. You're probably not aware, but the last time there was any new roles in general practice was 1966, which is a long time ago, when practice nurses were introduced. So in the last year, there's been the latest wave, which involves individuals such as pharmacists, physiotherapists, and what we call social prescribing link workers, who basically help people to who present with healthcare issues, but actually the underlying issues are more around non-medical issues. Now, the link workers take referrals from the general practitioners where they come across issues that are non-medical. The sorts of issues that they struggle with is At the moment, they struggle with understanding what statutory services and what charity-based services are actually active. So actually, if there was somewhere where they could actually get information about what's open, what's not, that will really help. I think the other thing that I notice as well is, as a clinician, is it's very easy for what ostensibly seems to be a stable condition can really destabilise very, very quickly. So that might be a partner who becomes unwell, where the healthy individual is actually struggling maybe with memory problems, or and that there is a sizable gap for that crisis management. And I know from a healthcare perspective, there's a commission service from Red Cross to help with individuals, but often that's overwhelmed. And so we're left with this situation where people need statutory additional services from local authority, but there's sizable waits for that. So those would be two areas that I would, I'd be interested to know when your workshop is, and if I can get to it, I will. But those would be two areas I think would be you only got an individual for a place, but that's somewhere, if you think of somebody being an asset where they can actually assist in those sort of areas, I think we could make a sizable impact.
Brilliant. If I could respond on a couple of those points. So I see these posts, and I mean, at the moment, obviously, 3 posts is nothing. It's just little drops in the ocean, and but we see them very much working with, and community catalysts have lots of models of how they work alongside social prescribing link workers. So I think, it's how we add value rather than any duplication, and I think that's really key. In terms of understanding what's out there, it's a constant, I think everybody's always mapping, always trying to map what's out there, and I think one of the strands of the corporate preventative strategy that is being developed at the moment is around understanding that we use the term community assets, which, but all the stuff that's out there, that's whether it's your local church or your self-help group or your leisure centre or your social care service or your, so all of the stuff that actually is in people's communities is absolutely key. And lots of people are trying to gather that information. And I think, again, as system-wide, we need to obviously make that better and make that work. And a lot of stuff came out of the community hub, which was, really powerful during COVID in terms of response to all of those vulnerable people that we've talked about today. In my team, we're responsible for Not Help Yourself, which is, again, now supposed to be the website that helps link that. We know it's not fit for purpose at the moment, I think it'd be fair to say. And we're trying to look with the hub about how do we join up that to make sure we've got the right information, because I think the thing that will help people help themselves and help practitioners help them is to know what's out there and how to join people up to it. So I think that is a really important thing, and so there is work going on with that. And the other bit, I know that, and it would be interesting to talk to community catalysts about crisis intervention, but I know that's one of the areas that they identified was that point of crisis and how do you intervene and stop something escalating. But so I'd definitely be interested to explore that further.
Thank you, Claire. Jonathan.
Thanks. Thank you, Claire. I think you know already that I'm really interested in this. There was just one point where I thought you might be about to explain a bit more, and then you moved on quickly. So I wonder if I could bring you back to it, if I might. I know that there are only 2 or 3 resources initially available to you. It sounded as if they might be deployed on the basis of who shouts soonest and loudest. And I think you've got more thinking behind that. And would you just say a bit more? Because obviously we need to be thinking about reducing health inequalities.
Yeah, so I suppose what Community Catalyst's advice to us was that you think about 3, because we want to work at a real PCN, kind of real locality level. And so we wanted to cover across North, Mid and South. And within that, we probably will want to look at perhaps at least one of those would be a very deprived community. At least one of those would be perhaps where there's a particularly prevalent condition that we might want to, so I think within that, so what I wanted to overlay with that, with the who shouts loudest, to say, actually, within your area, are any of these things applying that we can overlay? So yeah, you're quite right. But I'm conscious within each of those localities, we probably have that mix of, rurality or, deprivation or things like that. So so I was going to kind of do a bit of a blend of the two, of sort of knowing that we want to kind of target some key types of individuals and population needs alongside where there's buy-in and commitment. And if we can make those two marry up, I think that's the best way forward. But yes, you're right, and thank you for helping me clarify that point.
Thank you, Claire. The Health Board is asked to receive the presentation on the local area coordination in Nottinghamshire, and no doubt we'll hear a lot more as we go forward, and to receive the workshop on Wednesday, the 28th of July 2021. Thanks very much. I move it. We got a seconder, Jeremy. Seconder, all in favour? Excellent. So, thank you very much, Claire. We're going to move forward now to item number 11, the Better Care Fund year-end report, pages 41 onwards. Who have we got presenting the Better Care Fund?
That'll be me again. Sorry.
I thought I'd just say goodbye to you, Claire.
I won't dwell too long on this. So, the Better Care Fund is our large fund that is set by government about how sort of health and social care share a significant sort of funding allocation, and this is sort of subject to sort of annual reporting. And during last year, because of COVID, the government was very, very light touch in its reporting. So really, I'm asking you really to formally approve the submission of the 2021 year-end report, which has been kind of had the sign off by the kind of relevant senior people, but just needs to come here for sort of formality's sake. The report did highlight a few successes and challenges, and I just wanted to very briefly refer to those. And I think, again, inevitably they very much speak to COVID. The Better Care Fund, the key intention behind that is to support integrated working. That's always that was the premise behind it. And I think what's going to be really key going forward is to see how we better align the Better Care Fund to the integrated care system, because at the moment those two sit very separately, and I think there is, for me, there's a real challenge and a real appetite for bringing those together and seeing how we use those funding streams in a much more joined up way than we currently do. But the report highlights the successes we had around the local resilience forums, which were real, major mechanisms for bringing together the whole care systems together around CCG, districts, local authorities. Everybody was together in one place across city, Basildor. It was very, very inclusive in terms of approach. A particularly effective forum was the Home Care and Care Home Forum, which obviously had a really focused piece of work to do, and how we work together to support care homes and really develop some very, very joined up ways of thinking and working together. We ended up, from again, data was king to that in terms of how we reached the right care homes at the right time, in terms of all of the breakouts, etc. And there was an amazingly positive piece of really joined up working and a one version of the truth around the data, so that we weren't all talking to different data sets, we were talking to one data set, that we weren't bombarding the care homes with a million different messages, but we were working together, that we were going in and collectively from from all our different perspectives. And I think that was a really, really positive example of partnership working, and one that we're now taking forward as a long-term way of working together. And I think we're really proud of that example. Again, totally linked to the population health management and the work that's been already referenced about the GPRCC. The predictive analytic work is something, again, that's been really, really powerful and really helped us, and is something that we will be taking forward. I think one of the areas that was more challenging was around the discharging of people from hospitals into the community. But again, I think through local resilience forums, we worked really effectively around that in terms of we were able to redeploy resources, because we knew it was absolutely vital to get people out of hospital as soon as possible, so that we weren't kind of getting people sort of people waiting in hospital beyond when they were fit to be discharged. And we're continuing to be challenged by that too, as the temporary funding that was around to support that work is likely to end. We're trying to look at in partnership about how we resolve the issue of hospital discharge, particularly knowing that we've got a backlog of elective admissions which are going to need to be dealt with and are going to need to clear as much space in hospitals to allow that to be achieved. And we also just highlighted mental health, and again we've talked about that here today, that we know that's going to be a rising challenge that we've got to work on a partnership approach about how we meet that challenge. So we'll come back to the board later in the year to look at how we'll be the governance around the Better Care Fund. We came and talked to you in quite a lot of detail about how we wanted to do that, but because of the changes of the white paper and the integrated care system, I think it needs to evolve again, and so I think we need to look at how we do that to best effect. So there might be a further iteration that we want to come back and talk to you about.
Thanks very much, Claire. And no small budget at £100 million. It's grown exponentially over the years and has been a real model of success. Indeed, if you had a Better Care Fund that covered 3.5 billion, you would be the ICS, wouldn't you? Yes. So anybody got any questions with regards to the management of the Better Care Fund? It has been an unusual quarter and a delayed quarter, and we can't really compare discharge successes and failures, etc., with any other period in time because it's just not comparable. So I think we've just got to say well done for that quarter, and we'll see you again for the next quarter. Oh, hang on, Jeremy.
Hi, thank you for this. Just want to understand about the BCF. Is there any scope for widening the types of things that we can potentially do with it? In terms of, I'm just curious, that there is some work that I've seen which is around doing a variety of projects between primary care networks and local authority. And I'm just curious as to, I know it focuses very much on transfers and reducing admissions, etc. But I just wonder if, in the sort of spirit of integration, whether, I guess what we're seeing with as organisations move from localities into places, whether there's actually scope for doing some work using some Better Care funding for actually something at a place-based level that pertains just to that local community.
I think there's a real challenge at the moment. So the Better Care Fund started with a really transformational agenda in terms of, I think, how it wanted to work. And I use this phrase, so forgive me, Councillor, but it's become very transactional. It's basically become, this is CCD's money, this is local authority money, and there's not a lot of interplay between them, to be fair. I think that's something we need to challenge ourselves about going forward, and particularly around the integration agenda, about how can we differently align those budgets, even if it's, there's no new money in the system. All that money is pretty much dedicated to different things, but about how do we use those funds in a more flexible way around different agendas. I think what probably hasn't been, so I think that's one challenge in there. I think probably what hasn't been looked at in there is that place-based challenge, and perhaps that's something that, as we go forward with it, clearly as that's the direction of travel, we need to be thinking about place-based care. But I think the first, at the moment we've just got money in, money out, but I don't think we're doing anything except very much around the edges. Sort of, we haven't got the opportunity at the moment to do that differently, but I think that's something that we need to evolve, and I think evolve with the ICS.
Thanks very much, Claire. So it's a budget that's reasonably set in stone from its historical perspective. transactional rather than transformational, which is perhaps where you'd like to go. And it could be that the ICS use it as a vehicle to bring about the directives that come from joint strategic needs in the future, as it already exists. Thanks very much. That's a statutory obligation to receive the Better Care Fund on a quarterly basis, and I recommend that we approve the 2021 Better Care Fund end year, etc. for the 24th of May 2021. We've got a seconder.
Yeah.
All those in favour? Thank you very much, Claire. Before I say goodbye, have you got another thing to produce, Sarah? That's it. Thanks very much, Claire. Thank you. So we're going to move on now to item number 12, which is the Nottinghamshire Pharmaceutical Needs Assessment. The pharmaceutical needs assessment for the people of Nottinghamshire is a statutory requirement of the Health and Wellbeing Board to understand that we have enough pharmaceutical provision to provide for the needs of the population. Now, let's have a little look and see who's going to Mina going to present.
Thank you, Chair, for the introduction. Yes, this is a very short report on pharmaceutical needs assessment. So the purpose of this report is to update the Health and Wellbeing Board of the requirement to refresh our pharmaceutical needs assessment, and also update you on the approach that we have taken for refreshing this pharmaceutical needs assessment, or PNA, which would be for 2022 to 25, and also seek approval and advice of the board members. So just a very, as the chair introduced the PNA is a statutory duty of the Health and Wellbeing Board and need to be refreshed periodically. So currently is every 3 years, and the reason that it needs to be refreshed is that health needs and demographics and also pharmaceutical services will change throughout the time. So our previous PNA was published in 2018, and the next one was due in April 21. And because of the COVID-19 pandemic and the pressure that it inflicted on public health capacity nationally, the Department of Health moved the deadline from April 21 to April 22, and then this was followed by another extension to October 22. So October 22 is our current deadline. However, production of PNA and refreshing it takes, it's a big project, and it takes usually 1 year to 18 months. And again, because of COVID-19 pressure and allocation of our resources on COVID response at the moment, the decision was made within the public health team to externally commission this work for refreshing our PNA. And primary care commissioning CIC has been chosen. And the reason that this company has been chosen is because of their extensive experience in this area and similar work that they have completed at local, regional and national level within England and Wales. So primary care commissioning, or PCC, will be responsible for full project management and also presenting the completed work to the Health and Wellbeing Board. That would be near October 20, near the time that is the deadline, which is October 22. We have a PNA steering group that will oversee this work, and is a multi-agency membership. So Nottingham City Council has signed the same contract with the same company, which is positive and would contribute to the consistency of the PNA across the city and county area. And PNA steering group consists of myself as public health and commissioning manager, public health consultant, and our counterparts in Nottingham City Council and also other stakeholders. So we continue to provide supplementary statements during this time, as we have been doing since the publication of the previous PNA, and these supplementary statements are needed just to ensure that any gaps are identified and ensure that the pharmaceutical needs of the population are met. So the recommendations for today with this report is for the board to approve this approach, and near the end of the year we will come back with a more detailed paper and detailed work plan for this work as the PNA steering group meeting will resume in September 21 to provide support to the PCC for completing the work.
Thank you, Mina. The pharmaceutical needs assessment is, of course, one of our statutory duties which we have to provide. It's one of those things that sort of has evolved in a way that the locality needs are not necessarily now met by locality provision, and therefore if you look at things such as internet pharmacies and pharmacy to you, a lot of people access things in a completely different way than they did before, and therefore the physicality of the provision of service is more service driven now in terms of pharmacies providing minor injury care, perhaps flu jabs, perhaps medication assessments, etc., blood pressure monitoring, medication reviews, etc. And yet the pressure that they're under in a way by the or low cost basis of the potential Amazons of the future who can deliver your medication on the same day nowadays could remove the physicality, and therefore you could lose quite a substantial amount of the provision of service which aids general practice and flu campaigns, etc., etc. Is it likely that as we go forward that the requirements of what it says is to services to meet the needs of the population may have to vary because the needs of the population and the way that service is delivered is inevitably going to vary?
Yes, so there has been massive changes in the past couple of years in terms of internet pharmacies, online pharmacies, and also now all the pharmacies, as you may be aware, are required to facilitate remote prescription, so people don't need to go to their local pharmacy, as you mentioned. And also we have more digital pharmacies or online pharmacies, so people who are IT and internet literate and have the access can use those facilities. And in this new PNA, I actually made a query about this topic, and the response was that yes, all the digital and internet prescription and pharmacies will be included in the new PNA, which is good. But however, when it comes to actual PNA, it's about mapping, using the demographic and health needs of the population and the proximity of residential places and those group of population to actual physical pharmacies. So that will remain the main parts of the PNA. However, it will be supplemented, the information, with the changes in pharmacy, online pharmacies, for example, Pharmacy to You, that is basically delivering medications and prescriptions to people's houses. This will be included. However, private pharmacies, including physical and online pharmacies, will not be included because they are not commissioned by NHSE, so they won't be. And it will be very difficult to bring them into consideration in this PNA.
The other thing that raises its head a lot, I know Councillor Martin has raised it in the past, has been home delivery, and particularly nomads, which are, structured medication deliveries that allow people to safely take medication or saferly take medication. That's a service which has been under some degree of strain because of the amount of effort needed to go into it, and people were charging £5 or whatever to do home deliveries, etc. I think Boots started it off. Is that something that's covered by the pharmaceutical needs assessments, etc.?
Is that the private sector or?
No, it's by the pharmaceutical sector, Boots, etc.
Yes, I believe that's the service that delivers prescription to people's doorstep.
In card access, So that Monday, Tuesday, Wednesday, Thursday, Friday.
Yes, I believe that will be included. Yes, I believe so. This was, yes.
And considered to be a necessary part of any assessment.
It would be the supplementary part of the assessment, because it's still the main focus in the PNA is that everyone has that geographical proximity to a physical pharmacy. Yes. And in the previous PNA published in 2018, which is available on Nottinghamshire Insight as well, yes. It mentions that in Nottingham and Nottinghamshire we had comprehensive access. Sufficient. And I had a check just for my own knowledge. We had only one closure, or maybe two, because there was one recent one, 2 closures since then. And the most changes were about reduction in supplementary hours. So I myself didn't come across a massive difference or change in the pharmaceutical services that were analysed and studied back in 2018. And part of the PNA, part of what PNA does is that informs NHS England for pharmaceutical applications. And if there is a gap, there will be a priority for applications that come from that geographical area. So this is something that NHS England is covering and paying attention to as well during the gap that we have between the refresh of PNAs.
So the high street may be losing a lot of stores and a lot of businesses, but it's not losing the pharmacies.
Hopefully not.
That's what you say.
Yes.
Really. Councillor Martin.
I mean, I understand the reason for the delay in the because of COVID, but what I mean, community pharmacies are really important because they deliver other services as well, which support the doctors' practices. That's quite important, especially in more rural areas, because I mean, half of my parish, if they haven't got a car, they can't get to it. They have to get on the bus route. So that's one of the things that you may need to look at, that your pharmacies are strategically on a bus route, because I've got quite a lot of villages, Underwood, Westwood,
yes.
Bagthorpe, that they can't get to them without a car or somebody taking them. I mean, it was quite clear during the lockdown when we did these welfare checks that a lot of isolated people through COVID were frightened to go out. So I'm still fetching pharmacy for some people now. Even now, they're still ringing me up. When you talk about going forwards for 22-23, what will also be quite important is to look at the local authority housing plans as well.
Yes.
Because obviously that we're about to see a boom in that, a massive boom. You know, I mean, I think over the next 5 years, there's going to be thousands of new houses built everywhere. So that's another strategic, important thing to take into consideration when you're forming this strategy, if you can. I know you're up against it because the internet is killing traditional pharmacies, and that's just what's happened across the whole of the country. And COVID has exacerbated that problem. So it's a difficult strategy to lay out, really.
Yeah, so one of the reasons that production of or updates of the PNA takes 1 year to 18 months is that there's a lot of data analysis as well as mapping using geographical systems to look at the changes in housing and transport. So that is all included in the PNA. So that's why it all takes so much time to see the changes in housing, population, and even demographics. So how many women of childbearing age are added to that group to that area. It's because one of the services that pharmacists provide is, for example, contraception, emergency contraception, or for children, or full vaccination for people over age of 65. So all of these are basically considered when it's updated. So definitely population, housing, and transport are included.
I mean, one of the worst things for my area particularly was when the government changed the legislation about doctors' practices being able to prescribe pharmacy, because there are more doctors' practices in more locations than there were pharmacies at the time. And that created isolation, especially in Underwood, because we lost the surgery as well. So not only did we lose the dispensing element, we lost the surgery as well. So.
Yes, yeah. Unfortunately, there are differences. There are some pharmacies located, for example, in High Street. You can see a few of them, but then, as you said, in some rural areas, there are not as many. But all of these are considered. So NHS England would use the PNA and what's any gap that is identified in the PNA to make decisions on the applications that come to them. So, and also there are some schemes, government funding schemes that supports pharmacies that are far away, so they can maybe increase the hours or supplementary hours, so they can support the population that are around them.
Thank you, Mina. Councillor Schuler.
This may be my misunderstanding, but you're talking about the gaps and looking for gaps in provision. So if a gap in provision is that we physically can access a pharmacy, however, through different reasons, the person cannot get to that pharmacy. So we're looking at the delivery of medicines, etc. Would that be thrown up as a gap? So would that be fed back to NHS England to say that the needs, as Councillor Martin points out, that he's got a large rurality and therefore the actual delivery of pharmacy medicines is better than being able to physically access a pharmacy?
Yeah, that is a very, very good question, and I myself am very interested to know about that. So I can ask the advisor who's producing this work for us, because I think because of the changes, if, for example, in a rural area there are people, a big group of people over age of 65, that could be something to basically. Sorry, my package thing. Yeah, that could be something which could potentially close that gap. So I'm myself very interested. I haven't completed a PNA before, and I'm very new to the role. So I don't know about that, but I think that is a very interesting point, and I will find out. And I will Thank you.
Thanks, Mina. So effectively, where a service is not an effective service, really, do we pick up on the lack of effectivity?
Yes, yes.
So, yes. So, well, we'll be working together on it, Mina, as it goes forward, and no doubt we'll bring it back to everybody when it's completed. Excellent. So I'm just going to...
Thank you.
Thank you, Mina. So I'm just going to move that we approved a revised planning approach to the Nottingham Pharmaceutical Needs Assessment, identify any further points in progression, which we've noted a few points in progression, and receive a more detailed report towards the end of 2021, including the full Nottingham Pharmaceutical Needs Assessment Project Plan developed by the PNA Steering Group for the board to review and make any further suggestions. I'd just like to move that. Can I have a seconder, Jeremy? All those in favour? Okay, excellent. So moving at 5 minutes to 4, moving to the work programme, which is the last item on today's agenda, and item number 13. You can see that one of the things that's coming up is a feast of workshops. One on Wednesday the 7th, which should be very, very interesting on the mental health prevention. And all the associated partners involved in it. Mental health, obviously, a huge area over COVID, etc. And it was a huge area before COVID. So it's about, believe, an all age workshop as opposed to just adult mental health. And then there's an additional workshop towards the end of the month, which is the 28th, which we've heard a little bit about earlier, called the Local Area Coordination Concept, which is an interesting concept, but it'll be wonderful to get greater clarity on that. So that's going to take us up then to August, and then it'll be after that we're back again in September after the August break. It's quite a number of items there for your perusal. And no doubt over July, etc., now that we're back at reasonable strength, we'll be coming up with lots of ideas and lots of thoughts and lots of new items to be put on that agenda. Is that right, Martin? Yes. Councillor Martin.
Is that local area coordination, is that going to be like a brief overview of the integrated care system?
No.
No.
not to my knowledge.
Because for new councillors or councillors that have never come across that before, I think that might be worth putting in somewhere.
Go ahead, Jonathan.
So happy to provide that. There'll be several colleagues here who came along to the 1 o'clock induction session where we covered that, but I'd be more than happy for anyone who might want it to do a kind of a one-to-one session around what on earth is this thing called the integrated care system, and some of the structures within it. Yeah. So if that'd be useful to you, then yeah, give me a shout. I'd be happy to do that.
Okay, obviously it's the first meeting. It takes a little bit of time to see what the agenda is going to be like going forward, and you'll all formulate your own ideas related to your own communities and your own places, and I think that we'll have an abundance of potentials to add to the work programme going forward, but next time we'll see you, we'll hopefully be at the 2 workshops. Workshops are great fun, they're very interactive, and I think very enjoyable. So it is something to look forward to. And we don't just have one, we've got 2 of them. So you should be going home as the happiest people in Nottinghamshire. Okay, at 4 o'clock, I'd like to say thank you all very much indeed for being here today. And I look forward to seeing you at the workshops. Thank you.